Thank you, Bayer and the G4A team for inviting us to discuss how we can close the equity gap through democratizing healthcare. Well before the pandemic, going back decades truly, there were health differences between people closely linked to social, economic, and environmental disadvantages. Then COVID-19's toxic side effects beyond the virus itself led to further erosion of food security, financial well-being, and stressors on mental and behavioral health. For the next 30 minutes or so, we're here to brainstorm how to close these gaps. And as we begin, let me point out that equal treatment and equitable treatment are different objectives, but both are required to reach the aspiration of health equity. We have a trio of accomplished CEOs today to address the challenge as they've worked at doing throughout all their careers. That is absolutely the case, and we're so lucky to have these three expert guruses with us today. So Toyin, Donna, and Lisa, welcome. And let's get on to our mission to talk about this big, important subject. Let's start with each of you introducing yourself, your organization, and this lens on determinants of health, how these play into all of your work. Let's start with Toyin.
Thank you so much for having me. I'm Toyin Ajayi. I'm co-founder and CEO of CityBlock Health. We're a company that focuses on improving health outcomes for the most marginalized communities, particularly folks who receive their healthcare insurance through Medicare or Medicaid or both. We really focus on understanding the totality of each individual's health needs. And that is recognizing that often our social factors, our non-medical factors, where we live, who we live with, what we have to eat, how much income we have at the end of every month, are more important in driving our health outcomes than what diagnosis we have, what medicines we take, which doctor we see regularly. And so in order to achieve equitable health outcomes, we have to recognize that all of the things I described earlier, the social drivers of health, are not equally distributed or fairly distributed or equitably distributed at baseline. Therefore, they contribute to inequitable health outcomes. And so we have to understand and address those social drivers, even as we think about ensuring that, that the folks who we serve have access to the very best of the healthcare, the clinical factors, and the clinical inputs that we are able to offer as well.
Fantastic. Thanks, Toyin. Donna, why don't you tell us what you're doing with the Global Liver Alliance?
Sure. The Global Liver Institute is the only patient advocacy organization in the liver health space that operates globally. So it has been our challenge, or the challenge I'm privileged to take up, that our solutions should work in Kentucky as well as in Kenya in everything we do. As a liver transplant recipient myself, I know how rare it is to have overcome all of the stacks of stigma and inequity that exist for all liver patients, no matter the type of disease, and there are more than 100 different types, which is why we have 500 million people around the world who have them. So constructing the Global Liver Institute to make sure that we can have equitable distribution of all of the innovations that we know can help reduce the drivers of liver disease, the 70% of liver diseases that are preventable by vaccination or cures, or a dozen different supports, we know could have a huge impact on global health. And so it's exciting to work with my fellow patients on that challenge.
That's a big number that's preventable. You taught me something today, 70%.
Yeah.
That's incredible. So therefore, determinants of health play a huge role in the liver.
Absolutely.
Incredible. Lisa Fitzpatrick, So tell us about you, what you're doing at Grapevine, and these determinants of health that you're wrestling with.
Sure. Thanks very much. I'm really happy to be part of this conversation. I am a physician and medical epidemiologist. I worked at the Centers for Disease Control in the United States for many years. And I've also served as medical director for a Medicaid program. And so across all of these jobs I've had over the last 20 years, there's been a theme that I think is inadequately addressed, particularly for underserved communities, and that's the ability to understand health information and navigate the health system. So I established Grapevine Health, a digital health media company focused on improving health outcomes by helping people, particularly Medicaid patients and other underserved communities, to understand health information and health system navigation. And Grapevine Health aims to build trust and improve patient engagement among these overlooked communities through delivery of culturally appropriate and relatable health information. And I'll just share a story that helps folks understand why I felt it was so imperative to start Grapevine Health. Many years ago, I was conducting a town hall meeting in an underserved community, and a gentleman walked up to me and said, "How does someone like me access someone like you on a regular basis?" Now, this gentleman had a healthcare provider. He was on medications and found the language of his provider and all of the language associated with his health condition very confusing. And I realized there are millions of people, not just in the United States, but probably around the world, who struggle with health system navigation. So we want to support that. And Grapevine Health is a pretty new company, but I think we're on a good path, and we're getting some early proof points that show this is value added in the social determinant space.
That's fantastic. I think people sometimes paint health literacy as sort of one flavor, and it's not. It's got layers like an onion: health literacy, digital literacy, health system literacy, the navigation you're talking about, which I know Accenture recently did a study, and that adds up to zillions of dollars of waste when people have the benefit of the health benefit and they don't know how to use it. I'm a health economist. That makes me nuts. So yeah, thank you for that important work. And again, 3 different lenses on determinants of health, depending who we're serving, and that's what's so important. So let's really get into it now and talk about some of the practical, thorny learnings, the positive ones, and stuff that maybe didn't work so well. So I'm going to ask each of you, tell us a story about looking at a determinant of health or a constellation of them, and how you succeeded at dealing with a particular problem, and maybe how it didn't go so well and what you learned. So who would like to jump in first?
I'll go first. Before starting Grapevine Health, I had several of my patients tell me they didn't exercise because they didn't feel safe in their neighborhood, or they needed support for exercise. And similarly, people telling me, "I know I'm supposed to eat fruits and vegetables, but it's too expensive. Like, what do you recommend?" So we started an organization focused on these 2 things: health and nutrition literacy, and exercise. So we provided free exercise classes, health education classes. This started out great, but it soon failed because, number one, despite people telling us they wanted these things, having a brick and mortar space where we expected people to come ultimately just didn't work for them long term. They might drop in now and then, but the information, we needed to find a way to get information to people in places they were already consuming information. And the second reason it wasn't successful is because sometimes it's hard to find mission-aligned funding that will not construct so many barriers that it's hard for you to really focus on the work. And we just felt the climb was a bit too hard, and learned from that, though, because we still incorporated the information we gained from folks around this, why they liked the services, why they were not able to participate, how they wanted to receive information. And we're taking those lessons learned and integrating those into our workflow at Grapevine Health.
That's fantastic. You know, health behavior change is like the hardest thing to do for anybody. So when you have these barriers of brick and mortar or safe environments, think of how much harder it is for those folks. So good. Those are great learnings. Donna, do you have a story to share?
I do. We are also a rather young organization. And so it's less a misstep, but a frustration that we have been, gradually working our way out of. We started as a very grass tops organization, more policy forward and infrastructure. But we recognize that the um, community organizations really couldn't make the most of what we were putting together. And so we really reoriented during the pandemic. And I spent a lot of personal time um, mentoring and strengthening the community organizations individually. And so now I feel that we emerge in this year with a much stronger system on the ground, not just of individual patients, but of community organizations who understand the needs of their communities, are strong enough to do service. And so it makes the information and programs and works that we're putting out from our offices, either in DC or the EU or UK, penetrate much more deeply. And so now it's really getting exciting.
Are these organizations representing different parts of the ecosystem?
They are. They're representing different. Some are in different states. Some have multiple states or regions in Canada. It is encouraging, though, them to redefine how they reach out to their community. So they might have just thought that their community, for example, was the academic medical center next door, and helping them realize that the community is the church next door. It is the homeless organization. It is the Chamber of Commerce. It is the Native reservation next door, and so helping them recognize and redefine their own the communities, so that they'll be stronger, more diverse. More in touch with the true needs of their areas, and so our programs will resonate more deeply and penetrate. And we also, from our level, have the benefit of a more diverse and more engaged input into our councils and our Advanced Advocacy Academy, where we train people to go back into their communities. We have a much stronger pipeline now, having helped them reach deeper. So it's very exciting.
It really is very user-centered design thinking.
Yes.
I love
Yes.
that. Toyin, what's your social determinant of health story of woe or success?
Yeah, I think it's a both. I was caring for a patient, a gentleman who had a long history of every year, around about the same time of the year, we'd get hospitalized for a worsening of his chronic medical condition. And when I looked through his chart to sort of see if I could parse what was going on, there was a narrative in his chart about, doesn't take his medicines, and a perspective that was being conveyed amongst the medical team that he was not reliable, not responsible, unwilling. There were all sorts of tropes and sort of generalizations that people often tacitly and explicitly make. Particularly, this gentleman was an older African-American person, particularly about people of color. And so I was preparing to engage with him specifically about that. Is it a literacy issue? Is it that he doesn't understand how to take his meds? Is it that he's forgetful? Does he have, dementia? Is he unwilling to take his medications? And as I was talking with this gentleman in a visit that probably otherwise would have taken 20 minutes, he just needed a refill. We ended up talking for a really long time, and it became very clear to me that he was not disorganized. He was not unwilling to take his medicines. He was not uninterested in his health and well-being. In fact, he was all of those things. He was an incredibly motivated, very organized person, even though he didn't sort of come in the package that the healthcare system traditionally sees as organized. He's older, he's African American. He wasn't super tech savvy, but he knew exactly what was going on. And finally, I said to him, I don't think you're forgetting what's going on here. And he confided in me, and I found out later that it was the first time he'd shared with a physician that he couldn't afford his meds. And he was struggling to balance his bills and his obligations at home. He was embarrassed that he was in a position where he couldn't afford the medications that he knew he needed. And so he was stretching them. He would break them in half. He would, stretch out his doses. He would try to manage his diet so that he didn't have to take as many of the medications as he needed. And we were finally able to uncover this. And to the point, we were having a conversation before this webinar started about, and he also qualified for additional support that he didn't even know he had, because he'd never told anyone this. Because when you walk into an encounter and you feel judged and you feel prejudged and you feel like people expect you to not care or to not understand, you're lacking that basis of trust that would allow you to divulge this deeply personal and, for many people, a source of real shame. I've worked hard my entire life and I can't even afford my basic meds. And society tells you it's your fault. And healthcare tells you it's your fault. And then we resent you when you come to the emergency room in extremis because you can't afford your meds. And then you believe it's your fault. And this story for me is such an important reminder of, why we are so anchored at CityBlock on trust and those relationships, on really meeting people where they are, but doing so without judgment. Because when you judge, you close the door to full understanding. And the solve here was, the easy part was saying, oh, you qualify for supports to help you pay for your meds. That was the easy part. The hard part was getting through all of the muck of the relationship that helped us even understand what mattered for him. And that story for me was really one that stuck with me. It personally felt really wonderful to be trusted with that level of personal and depth of understanding and information. And when we think about screening for social determinants of health, I'm always reminded of, would I tell a perfect stranger that I am struggling with violence in my relationship or that I'm hungry? If they asked me, on a checklist as they were checking me in, what would it actually take for me to share that information? How do we create that sense of safety in order to earn the right to understand what we can then do to help people address their social needs?
It's a story we could unpack over the next hour. But you built empathy, and it speaks to what Lisa was talking about, that trust. Without trust, there's no engagement. And we really have to work hard on that. And then you took time, which is a precious resource from a clinician, to build that trust, to open up a safe place for him. And then the financial wellness story about access to meds, which is a uniquely American situation. And so you really opened up a lot of doors there. Anybody who just listened to you won't be able to forget and look away from what they heard and learned from what you said, which was such a rich scenario with so many lessons for all parts of the healthcare ecosystem. So thank you for sharing that. And in each of your three stories, learnings to unpack. So might have not worked optimally, but we learn, we pivot. And we're smart. We can do that. Isn't that amazing? So each of you is active in working with these different challenges, determinants of health, and each of your organizations uses technology in a new way to scale a solution. So it can't just be boots on the ground with community health workers, as much as we love community health workers, because human capital is so scarce. We're in the great resignation period where we're losing a lot of people in healthcare, whether it's nurses or home health workers, and even physicians planning to quit in the next 5 years in larger numbers than anybody really would have anticipated due to burnout and unwellness. How does each of your organizations look at technology to scale in this empathic kind of way that each of your organizations also embrace? Because I think it's possible, and I would really love to hear about tech and empathy and scaling for success. So who wants the first bite of that apple?
I'm happy to go. I am so excited about how I guess I'm excited today. I'm just very excited this morning to be part of this. But it's the opportunity that gives me such great optimism, and how people light up when they are put in a position where they are helping to deliver solutions, not just having medicine done upon them, but feeling that they have a role in making their own health journey better, easier, and helping others. And so one of the things that we've started to do in our Advanced Advocacy Academy is to train community digital ambassadors, so that it goes beyond running a webinar on how to use your patient portals. Can we have people who will sit next to other people and walk them through how to sign in their device, walk them through how to view and look at their health data, how to use proxy access to take care of their mother or grandmother, and so that hands-on help and training is I think really proving essential to people having and using these tools. It's great to have them, but what we were trying to solve for is why aren't people using them? And so you talked about we can't have enough community health workers, but making sure that we are getting the input from community health workers, so we're solving for the right problems, is how we came about this program, as well as structuring more opportunities to capture data from our community health workers so that we continue to be solving for the right problems.
That's fantastic. Thank you for sharing that. Lisa, you've got to be using tech because you're this health media kind of offering. How are you looking at the tech scaling opportunity?
Well, for us, it has to be through smartphones. And before I say a bit about that, when I started talking to people about Grapevine Health, especially funders, one of the first questions they asked me was, do poor people have smartphones? Do they have access to the internet? And I'm still astounded that I still get this question, even now. People have access to smartphones. And we talk a lot about the absence of broadband in the US. But if you look at the data, 11 to 20% of people don't have access to broadband, which leaves 80% of people with some access to broadband. But if you look at smartphone ownership, it is well above 90%, even in the people we're serving. And so part of our discovery has included understanding what people are doing with their smartphones. And they are doing the same things everybody else is doing. They're watching YouTube videos. They're scrolling on social media. They're Googling. They're listening to Pandora and Spotify. The health sector is way behind when it comes to engaging people in the channels they're using for other things. So our goal, or my vision at Grapevine Health, is that we will also be in those spaces, and we can work with partners to help them be in those spaces, because otherwise the messages we're sending out through traditional channels, asking people to go to websites or sending pamphlets to their homes, we've been doing that for decades and decades, and we know it's not helping to better engage people. So the way we scale is to find ways to reach people in the places they're already paying attention through their smartphones. And we have a couple of proof points already that are very promising, that show there is a road to a path to making this successful and getting people to pay attention. And finally, I'll just say I'm always so privileged when I feel privileged when I hear Toyin talk about trust, because that's what we see on the ground. It's the same with sending messages to people. You have to craft the message in such a way that you don't feel like a stranger. People don't want to hear or get information from people they don't know and trust. And so that's on our roadmap as well. It's one of our values. We have to build trust through relatability so that people will pay attention and take the advice we want to give them to help them navigate healthcare.
So great. I hearken back. I studied a lot of media in undergrad, and we learned about Marshall McLuhan, who said the medium is the message. Here, the medium's the message, and the message is the medium too, because that's the trust, that's the voice, that's the trusted on ramp to, and then people are more likely to listen. So that's a wonderful
And the messenger
explanation.
too. I
Thank
didn't
you.
mention the messenger is very important. We
The
saw
messenger is the
that. We
message.
saw that during the
Yeah.
pandemic. Black doctors talking to Black communities who are vaccine hesitant. So, and the same with Hispanic communities. So, I think we can't forget about the messenger and the message together.
Donna, you want to add to that?
I absolutely believe that the part about the messenger and the corollary to trust, though, while we're, as a patient, while we're waiting for that, waiting for, and Daryl Gray from Chief Equity Office of Anthem used this fantastic phrase of cultural humility. Until we're waiting for providers to have greater cultural humility, in addition to competence and all of those things, what we teach our patients is it's give them confidence and a sense of belonging. So we talk about diversity, equity, and belonging because I've been in a lot of too many clinical situations, personally myself, and what has allowed me to survive to this point, 27 years post transplant, with all of the ologists that I have, is a confidence that I belong there, that I deserve the care, that I deserve the best care, and so to help people have the confidence walking into any healthcare setting that. Maybe this wasn't built for you in mind. No matter, you're here now. It now belongs to you. Use that time with, make sure the doctor answers your questions, bring them in a list, we train them how to make the most of their doctor's visits, which questions to ask, what images and things and a group to come back to and discuss it. And so that confidence is the corollary. If you don't have a trusted relationship or if you're building up to it, but if you come in as a patient with confidence and a sense of belonging, that can go a long way in any situation.
Toyin, City Block's been scaling for a while to really patients with chronic conditions with a lot of different issues they present with. How are you using tech to solve these challenges?
Yeah, I think the first piece very much reiterates, I think, what Lisa and Donna spoke about, which is recognizing, first of all, that low-income communities and communities of color absolutely do use smartphones, and the challenges are around data access, around privacy, and deeply, deeply around trust, making sure that the medium, the messenger, and the message are all trusted and trustworthy. I really like that. I'm going to borrow that. And so that's critical. But the other piece is recognizing that technology is now part of the way that we do business more broadly in healthcare, and that using technology with a focus on how do we ensure that we as an organization can keep our promises, can show up for our members when they need us with the right resources and structures and systems that they need, is also important. And so we think about the use of technology on the back end too, to power our business, the data, the insights, the analytics that help us know when a person's hit the emergency room, or more importantly, when they're about to, and the ability to dispatch clinical teams to their homes, or virtually, or to help folks come into the clinic to get seen so we can avoid a hospitalization that is going to be often traumatic for them or re-traumatizing for them, and very frequently not really delivering preventive services that we could deliver better and more effectively in the home. And so we think about technology really as a major driver of our organization in terms of enabling us to be consistent, to be reliable, to be trustworthy, to be scalable. And then we think about the ways that we use technology specifically to interact with our members, enabling us to be there for them 24/7. In a way that healthcare typically has not really prioritized being available for patients, particularly lower income patients, historically. And so that those two sort of vectors for us are critical.
I mean, we could use another couple hours, Bayer, next year. I want to give you each 1 minute to leave people with what you want to say about democratizing healthcare and social determinants. What's the root of the root that you want people to remember from our conversation? Donna, we'll start with you.
Sure, thank you. Equity is scalable, is my key takeaway. I hear a lot of fear within the health systems that to be able to give individualized, personalized, patient-centered care to meet the different needs, whether it's for food or transportation or whatever it is for a patient, to have their best outcome, that's just impossible for a system to do. And so, chair a lot of committees and do a lot of work helping them understand how it's not only feasible, but it is necessary. You can't have population health without individuals being healthy. And so I would say that equity is scalable. We just need to work on the how, but it's not an if.
Lisa?
I would say health literacy is a social determinant of health. It's often overlooked. People don't necessarily like the term health literacy, but I think that's because traditionally there's been a lot of judgment linked to health literacy. But I want to remind folks that the health sector, health providers included, have a responsibility to help people understand health information and how to navigate the health system. So when we think about health literacy at Grapevine Health, it's not that the onus is on the patient or the community member. It's not. The onus is on us to make sure we are doing our part to help people make healthy decisions for themselves and to engage in the health system in a way that's most convenient and accessible for them. So I want to flip the perspective people have about health literacy, but remind people that it is definitely linked to poor outcomes and avoidable costs in our healthcare system.
Fantastic. Thank you for that. And Toyin, your root of the root point.
Yeah, I really I enjoyed the title of our panel because it made me think about a whole bunch of things. The use of the word democratizing, given the ways in which our democracy does and does not work for marginalized people today, was a really interesting one for me. And so the root of the root here is, if we choose to frame ourselves around equity, we have to really be intentional about defining and redefining what that means. And maybe we can leapfrog a whole bunch of other institutions in this country and systems in this country that have yet to achieve that goal, that promise around what democracy really means. And for us, using that frame, it's provocative actually for me, because it says, how do we do things differently here? How do we think about the root of whose voices are heard, who has access to buying power or consumer power or decision-making power, whose experiences inform what gets valued and what gets invested in, because that is the root of democracy. It's equal voice, equal vote, equal for a person. But we know that the structures in which we govern our systems offer other people more power, depending in most instances on socioeconomic class, status, race, legacy. And we have to really be intentional about undoing that as we think about delivering health equity. So I'm grateful for that. I think the call to action for us here is to really, really continue to pull the string and unravel the ball. And let's get back to the root. Let's get back to the beginning, and that is centering and recognizing and valuing the voices of those who have the most to lose and the most to gain from the status quo. And those are folks who are marginalized in our systems and our society.
I'm smiling because you're speaking my language. When you meet somebody who, all three of you, who are my sisters in this journey, I want to conclude with a quote from one of my gurus that I look to for truth and evidence-based, and that's Dr. Donald Berwick. Just days. It was unbelievable how JAMA pivoted quickly after George Floyd died. Was murdered, died, passed away. Don wrote an essay in JAMA called The Moral Determinants of Health, again, within a couple weeks in that June month of 2020. And he concluded this essay on the moral determinants of health with the following. I have my printout of the PDF here. This is the last paragraph, just a couple sentences. Healers are called to heal. Toyin, you said something like that just now. Healers are called to heal when the fabric of communities upon which health depends is torn. Then healers are called to mend it. The moral law within insists so. Improving the social determinants of health will be brought at last to a boil only by the heat of the moral determinants of health. I posit that the three of you are implementing approaches to social determinants of health with a moral conscience, with a mission. And that's how we're going to get to democratization of health, when we treat each individual as a health citizen with rights to health and dignity and, and an on-ramp to trust. So thank you, all three of you, for being part of this. Thank you, Bayer, G4A, for hosting us. And I wish everybody well and health. Thank you.
Thank you.
Thank you.